And Katrina, you want to describe how to participate?
Yeah, absolutely. Hi, everyone. We're really glad to have you here today. My name is Katrina, and I am the chairperson for this webinar. I just want to let you know that everyone will be on mute on the audio portion except for the presenters at their portions of the webinar. Participants can ask questions via the chat function. I will be flagging questions as they come up throughout the presentation, so if you ask a question in the chat, I will flag it and it will go to a separate tab that we as the presenters can see. So whenever you think of a question, even if it's before the Q&A session, please don't hesitate to ask. All questions do need to go through chat. And during the Q&A portion, you will be able to raise your hand. You should all see like a raise hand button. If you want to try that now, raise your hand and then unraise your hand just so you can try it out. We will be answering questions via the hand raise function during the Q&A section. If you raise your hand during the rest of the presentation, we will not be answering questions. So you should just use the chat function at that time. I think that's about it. Rebecca?
Thanks, Katrina. So again, this is the End of Life Care Program webinar on proposed Medicare fee rule change for advanced care planning. I want to welcome you, and my name again is Rebecca Johnson. I am Associate Program Director of Graduate and Professional Studies and will be your moderator today. The agenda for, sorry, I'm having a little, there we go, slide moving problem there. The agenda today includes presentations on the history, regulatory, and legislative process for making advanced care planning available to Medicare recipients. There's an overview on how to engage the comments on the rulemaking process, and I'll be presenting information about the Sarah Lawrence College End of Life Care Program. There are 4 poll questions within that webinar that we'll be asking you to answer and will enhance your participation. I'm pleased to introduce, oh, sorry, my slides are moving without me doing anything. I'm pleased to introduce our speakers. So let me introduce Joshua Lapps. He is the Government Relations Manager at the Society of Hospital Medicine. He is responsible for developing strategies to identify and educate hospitalists on key public policy issues, and he leads the growth of membership capacity for grassroots political advocacy. Deborah Jones is an Indiana-based health advocate who brings to health advocacy an extensive corporate background in strategic planning and change management, particularly with respect to employee health and welfare benefits. So I'm just going to go ahead and let Joshua get started. Joshua?
Great. Thank you so much, Rebecca, and welcome, everyone. I'm very happy to be here with you today to talk about the work that the Society of Hospital Medicine has been doing on advanced care planning, and also to give an overview of the history of what's been going on over the past few years in advanced care planning. So just a little bit of kind of boilerplate background on the organization that I work for, the Society of Hospital Medicine. It's the largest national professional organization for hospitalists. We're home to more than 14,000 members of the approximately 48,000 hospitalists nationwide. And our mission is to promote exceptional care for hospitalized patients, and we do that through offering continuing education opportunities for hospitalists, such as CME and in-person meetings, as well as opportunities for publication in our peer-reviewed Journal of Hospital Medicine. We also have a robust quality improvement organization that does projects at hospitals nationwide. And then lastly, the work that I do, the advocacy and public policy work, a lot of the sort of behind the scenes working with Capitol Hill to affect change. So to give you a little bit of a sense of why hospitalists care about advanced care planning and what got me involved in this, hospitalists, as many of you know, are inpatient primary care physicians, and so throughout their work, they're really typically dealing with two types of patients, the acutely ill patients and the terminally ill patients. And so they're often dealing with patients who are confronting questions of their course of treatment and confronting questions of how they would like to be treated at the end of their life. We know from the CDC study back in 2005 that approximately 50% of deaths occur in a hospital setting, and that number has not changed significantly over the past few years. And so hospitals really are kind of the front line for a lot of patients when they're confronting issues of end-of-life care kind of in the real time. So many patients that hospitalists are seeing do not have advanced care plans. And part of that, I think, is because it's very difficult to have this conversation, and it's really not clear when patients are seeing multiple providers who should be having this conversation. So if a patient, for example, has a couple of specialists, a primary care physician, and a number of other providers who they're consistently seeing, it's really unclear whose role it is to be having this conversation. And then what brings us to the conversation today is that up until now, there's been a lack of financial or resource value attributed to advanced care planning. And really, without having that sort of value attached to it, it's been very difficult and very piecemeal of a process to have advanced care planning conversations. And then for patients who do have advanced care plans, there are a lot of issues with access to existing advanced care plans. So electronic health record systems, many hospitals, most hospitals actually nationwide, have EHR systems. But the interoperability of one EHR system to another is just not there. So even if for example, a patient does have an advanced care plan that's documented in their record, it might not be able to be passed from one EHR to another. And then another issue that is consistently a challenge is access to outpatient primary care physicians. So if there is an advanced care plan, figuring out, working with the patient who may be in a state of crisis, who may be confronting a very acute illness, to figure out who has that plan and where it's housed and getting access to it. So all of that leads to kind of a piecemeal application of advanced care planning across the nation, and really up to kind of the providers and the patients working together where it's available. And so for hospitalists, we say that hospitalists are really confronting these issues in real time for patients in crisis. And that's sort of the perspective that brought us to our work organizationally around advanced care plans. So to take a step back and give you a 10,000-foot view of the work that I do, policy changes are sort of, I like to think of them as interrelated pieces that fit together, sometimes spin in opposite directions, sometimes stop the other pieces from functioning. But ultimately, you need to have all of these pieces in some form or another in order to get sort of a policy change established. So the regulatory work is really the executive branch of the government working with the Centers for Medicare and Medicaid Services. The legislative work will come as no surprise, is working on Capitol Hill and working with Congress, which can be, needless to say, a daunting task these days. And then the important work that folks are doing, folks like myself, folks like who are working at consumer groups, and individual citizens who are speaking up and advocating for change. All of those things kind of work together, work with each other, sometimes work against each other, but ultimately work towards affecting change. So I want to give you a history of advanced care planning and I'm going to break it apart into two separate areas. The first will be legislative efforts. So I'm going to take us back about 5 years, I guess about 6 years almost now, to the Affordable Care Act and conversations that were occurring on Capitol Hill around advanced care planning in the context of the Affordable Care Act. Prior to the extremely contentious fight to get the Affordable Care Act passed, advanced care planning actually was a fairly bipartisan enterprise. There was support within both the Democrats and Republicans to include a provision within the Affordable Care Act to pay for advanced care planning services as provided by Medicare providers. And the legislation in the Affordable Care Act, the section in the Affordable Care Act, was actually based on legislation by a Republican Congressman, Charles Bustani, from the 3rd District of Louisiana. And that section really was very simple, would authorize payment for voluntary counseling and advanced care planning. Unfortunately, we all know what happened with that. The provision for advanced care planning in the Affordable Care Act was described inaccurately as a death panel by Sarah Palin and picked up throughout many media outlets. And ultimately, the advanced care planning was deemed too toxic, too much of a kind of wedge issue to be included in the Affordable Care Act. And so it was taken out before the legislation was considered for passage in the House and Senate. So in the wake of that sort of turbulent experience with advanced care planning on Capitol Hill, there emerged Representative Earl Blumenauer, who's been a steadfast supporter of advanced care planning and end-of-life care. He's a representative from Oregon, the 3rd District of Oregon, and since the Affordable Care Act brouhaha around the Advanced Care Plan Code, Representative Blumenauer has introduced his bill, the Personalize Your Care Act, in the next 3 subsequent Congresses. And so this bill would authorize payment for advanced care planning, similar to what was in the Affordable Care Act, but it would go further and establish grants for statewide PULSE programs. PULSE is physician orders for life-sustaining treatment. And so that would help states set up or help augment the systems that states already had set up in place for advanced care planning. And then the other very important piece of this legislation is that it would guarantee portability across state lines. So if you live in Virginia, you make an advanced care plan with your physician in Virginia, and you travel to Maryland or Kentucky or California, your advanced care plan would be accepted and considered to be sort of legally binding as appropriate. The current Congress, this bill has not been introduced, and you'll see why in a few minutes. One of the major pieces of this legislation is actually gaining some traction and gaining steam on the regulatory end of things. And so it's not clear what will happen with this bill in the wake of some regulatory changes, but there are some important pieces there that we think, my organization thinks, should still be considered. So with that, I will jump over to the regulatory efforts and give you kind of background around what's been happening behind the scenes, both within the Centers for Medicare and Medicaid Services and also on the provider end of things. So there are 2 recently created advanced care planning codes, and those are CPT codes, or Common Procedure Terminology codes, and they are 99497 and 99498. 99497 is the first visit, the first 30-minute code, and so that code would cover counseling and discussing advanced directives with or without completing any legal forms, and some examples of what the advanced directives or advanced care planning activities that could occur in these codes include healthcare proxies, durable power of attorney, living will, PULSed, physician order for life-sustaining treatment, and MOLST, medical order for life-sustaining treatment. I'll note that the codes also allow other qualified healthcare professionals to perform the services, and that's ultimately a sort of a piecemeal effort. It depends on education, training, and licensure, and ultimately facility privileging. So really, the state, local, and hospital policies all interact into who, beyond the physician, is qualified to provide these services. 99498 is an identical code, except it's each additional 30 minutes after providing the 99497 services. So these codes were actually established in 2014. They were built out of a proposal by the Illinois State Medical Society. They drafted a proposal and sent that over to the American Medical Association Common Procedure Terminology, or CPT, editorial panel. The CPT editorial panel is tasked with creating all of the codes that are used nationwide, and they ended up creating codes 99497 and 99498, and they were released in August of 2014. And the goal with these codes was that they could be used by commercial insurers and or Medicare beginning January 1st, 2015. Up until now, however, there's not been great evidence, and I've not been able to find evidence of them being used by commercial insurers. And as you'll see in the next slide, they've definitively not been used by Medicare. So in the 2015 Medicare Physician Fee Schedule, which is the yearly rule that comes out that guides physician payment programs, it was issued in November 13th, 2015. And for the calendar year 2015, I'm sorry, it was issued 2014. For calendar year 2015, CMS, the Centers for Medicare and Medicaid Services, assigned those two codes an I. And what the I means is that the codes are not valid for Medicare purposes, and that at this time Medicare believes that there's another code that these services are covered under. And really the thrust of the reasoning behind holding off on implementing these codes is that CMS wanted to go through the notice and comment rulemaking process. They wanted to solicit public comments before they implemented the codes. So the work that we've been doing on behalf of hospitalists and on behalf of the healthcare system, hospitalists have been actively supporting the Personalize Care Act. We have taken hundreds of hospitalists to Capitol Hill for congressional meetings, and one of our key issues over the past 2.5 years has been advanced care planning and increasing access to advanced care planning services. We've also been doing a lot of grassroots outreach and having folks call or email their congressional offices. The result of that is, we've been able to increase the number of co-sponsors on the bill, but also increase visibility of the issue. And we've also been supporting the implementation of these two advanced care planning codes. And so part of that has been joining in a multi-stakeholder effort to encourage CMS to implement these codes, both last year and throughout the beginning of this year. We have signed on to letters asking CMS to implement these codes quickly and ensure that patients have access to these important services. And we'll be providing comments on the 2016 Physician Fee Schedule proposed rule, which, as you'll see, is one of the asks towards the end of this presentation, is to really share experiences, and we'll be sharing experiences of hospitalists around these codes in the rulemaking cycle. And I'll explain a little bit more about the rulemaking cycle in just a minute. To give you a little bit of background on our perspectives and what we're commenting on for these codes, we obviously support the codes, but beyond that, we want to ensure that although there aren't any restrictions in any of the proposals today, we want to ensure that patients have access to these important counseling services in the hospital, in nursing homes, at home, and with their outpatient providers. So we want to ensure that patients have access to these conversations and have access to their providers to have these conversations in whatever setting is appropriate for them. So I'm going to very quickly go through an overview of the regulatory process. The basic regulatory process, and this is highly, highly simplified, is that Congress will pass a law, and the law will authorize a federal agency to act. That federal agency, for the example of Medicare, is the Centers for Medicare and Medicaid Services, which falls under the Department of Health and Human Services. That agency will then issue regulations, and so these two advanced care planning codes, the law that allows CMS to contemplate using these codes would be the law that gives Medicare, the Medicare statute, the law that gives CMS the authority to govern the fee schedule for physicians, to change valuations over time, and to kind of make adjustments to the program as needed. So regulations are created in a very, very structured process, and this process is called the rulemaking process, was established actually in 1946 by the Administrative Procedure Act. Technology and access to information has changed drastically over the last 60 some odd years, but the process by and large has remained the same. So typically there's some form of pre-rulemaking, and these would be more informal conversations, stakeholder conversations, talking to folks who will be affected by a rule, kind of fact-finding and information gathering. That can also be formal requests for information where the agency, where CMS will send out a request for formal information on a topic that they're interested in potentially creating rules around. When the agency decides that it's ready to propose a rule, they issue a Notice of Proposed Rulemaking, an NPRM. It's publicly available, published in the Federal Register, and given a public comment period. Typically, there are 30, 60, or 90-day comment periods, depending on the size and scope of the regulation and the impact. So after the public comment period, where organizations like the Society of Hospital Medicine, organizations such as beneficiary groups or other interested parties, as well as individuals who are interested in a particular issue, have the ability to provide comments on any of the proposals in a given NPRM. After the comments are collected, they are discussed in and written up in a final rule where the agency makes decisions about what they would like to do. So the physician fee schedule, just again, is a cyclical rule. It happens every year because it updates payment policies. It typically is proposed in the summer just before the July 4th holiday, and it's finalized in the winter, sometime around early November, to be put into effect for January 1st the following year. So in the 2016 physician fee schedule, which was issued July 15th, the comments are due on September 8th, 2015. Medicare is proposing to change the status indicator for these two codes from an I to an A. And the A code would mean that this is an active code for the purposes of billing Medicare. So these codes would be separately payable under the physician fee schedule and there are relative value units, or RVUs, for codes with this status. So these codes would be available for use. If finalized, these codes would be available for use January 1st, 2016. And I'll note that although Medicare does not have a national coverage determination, which would be kind of a binding national, this is how these codes should be used ruling, the Medicare contractors would create local coverage decisions about the use of these codes. So there could be some variability across the country of how the codes are implemented. So specifically, Medicare is seeking comments on whether payments for these services is needed, what types of incentives, good or bad, unforeseen or unintended consequences that this proposal could create, and whether or not payment for advanced care plan is appropriate in other circumstances. So should this be part of an optional piece of the annual wellness visit? So there's kind of a broad framework with which you can direct your comments. Again, this is some of the acronyms that I've used, and I will actually kick things over to Deborah Jones, who's going to talk about the ask and taking what you've learned over the past 20 minutes and putting it to action. So, Deborah?
Josh, thank you very much. It's interesting that you had a slide there of acronyms, because there are a lot of acronyms, a lot of numbers in the proposed rule change, and making public comment is something that might be a little bit intimidating to some people. So we wanted to talk about that, particularly when it comes to the general public. So we are providing support for everyone when it comes to making the necessary public comment. So as it says here on the slide, who should comment? It should be everyone, because, frankly, the bottom line is that we all have a stake in advanced care planning in one way or the other. So for those of us who are in a position to advocate for this measure, we can also encourage other members of the general public with whom we come in contact to make comment as well, because after all, when you get right down to it, we are talking about quality of life conversations. And furthermore, CMS delayed making these codes active specifically in order to allow public comment. So we should really take advantage of this. It's an open period that will allow us to advocate for care that's going to reflect the wishes of patients basically at any stage of life. When should you comment? Well, I think you know by now you should do it now. And for these reasons. When you comment, you're going to underscore the fact that advanced care planning is really an integral service in medical treatment planning. We want to underscore as well the need for ACP to occur when patients are both well and ill, which is why we need to have a code for repeat payments, because obviously health status changes over time. The impact of ACP on the inclusion for physicians and skilled nursing practices is kind of important, because they can plan better in terms of staffing and training. We have talked about qualified medical professionals being able to use the code as well, and I've seen some questions pop up on the chat regarding that very thing, which we will get to shortly when we get to the question period. So physicians' practices and skilled nursing practices need to be able to plan better. Also, your comments will underscore an urgency to creating a culture of comprehensive health care that's informed by patient choice. Isn't that the direction we've been moving into? I mean, really. And there's an imperative to raise public consciousness regarding end-of-the-life planning. Now, there are some other considerations as well. Some of them are economic. Some have to do with the visibility of palliative care, for instance, as a treatment option. And by having advanced care planning, it allows time for actions, which might include a change of providers to ensure that a patient's wishes are going to be followed. So all of these bullet points that I've just gone through have been pulled together into a sample comment. And this is just the opening paragraph of that sample comment that you're seeing up on the screen right now. And as is noted at the bottom of the slide, the full comment is going to be emailed to all participants. So what we've done here is try to capture the points that I mentioned, as well as some other points regarding POLST and MOLST and the continuity of care. And finally, the rule change, when it's enacted, and let's be optimistic. You know, I'm standing up here because I'm so excited about all this. When it's enacted, it will send a message that CMS stands with Medicare beneficiaries, because after all, you know, the baby boom population is swelling the ranks of those beneficiaries and is much more likely to demand the right to make some autonomous decisions about end-of-life care. So again, this is an example. So if you as an individual or your organization choose to use it, just make sure you refer, or choose to adapt it rather, make sure you refer to CMS 1631P in the comment so that you know that your comment is being properly directed. Now, not everybody has submitted comments before. I automatically thought that I would go to cms.gov. Well, that's not where you go. You go to regulations.gov. And in the case that you're seeing up here, the screenshot, what we did was to put in the search term, physician fee schedule, for the calendar year of 2016. And what it does is bring up, as you can see, 243 results. So how do you know you got the right one? Well, the comment period, which is that area that's circled in purple, should say September 8th. And you know that you're on the right one. You click on that. And when you click on Comment Now, you'll go to a next screen that looks like this, and it will confirm for you at the top. You are commenting on the proposed rule. So there's a field there. It's very, very easy to enter these electronic comments. You can enter your own. You can use the sample comment. If you choose to use the sample, at the beginning it says I or we, so select the right one, and go in and paste it in. And down below there's additional contact information that you need to fill out. Now the contact information, some of which will be visible on regulations.gov and some won't, just to protect privacy and that sort of thing. You'll have a chance to preview your comment, and when you submit it, you will get a receipt. And the importance of the receipt is this. Comments are not put up instantaneously. They're vetted first, and then they are posted on the regulations website. So if you keep your receipt number, you will be able to go back and check the status of your submission. Okay, so again, summarizing, it's regulations.gov. You can use the search terms physician fee schedule for the calendar year of 2016, and then go ahead and follow those screens. Okay, and Josh made reference to the ask. Here it is. These are the key dates. I feel a little bit like PBS Pledge Night. This is what you have to do in order to support Medicare payments for advanced care planning. By September the 8th, you have to have your public comments in. Now, we've been making the assumption that you would be using electronics. Well, not everybody necessarily wants to use electronics, so if you're using something non-electronic, like U.S. mail, or you're using express delivery, FedEx or UPS or something like that, it has to be at CMS by 5 p.m. next Tuesday the 8th. And the address is on the regulations.gov website. If you are going to use electronic, it's got to be in 11:59 p.m. So just remember, you've got 2 deadlines depending on the means you use. They will not accept faxes. Another key date, by November 1st, that's when CMS anticipates it will make the final rule announcement. And we want that rule announcement to permit reimbursement for these conversations. And then, as has been pointed out, January 1st is when the new physician payment schedule will go into effect. Today is September 2nd. Here's the ask. make sure you get your comments in quickly. And with that, I want to turn it back over to Rebecca so we can have questions and answers.
Well, thank you. Thank you, Deborah and Joshua. That was very informative, and we have a bunch of questions. Let me just first answer Mary Kay's question. You will be getting the slides, and a link will be included on regulations.gov, and you'll receive a download of Deborah's sample comments. So that'll come actually before the link to the slides, so that you can have that to answer our request that you get out there and make comments and get other people to make comments. So we have we have 7 questions, answered 1. So here are the other questions. So from Jennifer, I am the palliative care provider for my hospital. I am certified in hospice and palliative care. Would my hospital be able to bill for my discussions with Medicare patients? Joshua?
That's a great question, and I think that there is a couple of similar questions around this. Unfortunately, I can't definitively say whether or not a particular provider is going to be able to bill for these codes, in part because there's going to be local coverage determinations by the Medicare contractors. So there are a number of Medicare contractors that provide the kind of billing around the country. So there are different regions of the country, and with local coverage determinations, there could be some rules that are placed upon who and how the codes can be billed. The other piece to the puzzle is what I mentioned previously, which would be the state level and local level regulations in terms of the scope of work of a particular provider. So if the provider is privileged and licensed, and the regulatory bodies at the state level and local level have signed off on providing a particular set of services, they would kind of qualify under the definition of qualified provider. So I can't give a definitive answer for any one particular provider, but I can say that it's going to depend on a couple of different factors that I outlined.
Thanks, Joshua. I think that probably pertains to Amy's question about are social workers considered qualified to facilitate ACP conversations. Again, this regulation will pay nationally, but how it's implemented is a local and state issue. So, which sort of gets to Betsy Clamford's question about what is CMS's objection to implementing the CPT codes. And I wouldn't say it's an objection, but I would say it does have political implications. So, Joshua, do you want to reiterate any of that from your presentation?
Sure, yeah. I think if you look back at the history of the Advanced Care Code, there was a pretty strong rebuke of advanced care planning back in 2009, 2010. At least a political rebuke, although I think providers have remained pretty consistent in their support of advanced care planning. So the political costs in terms of implementing advanced care codes, they're not necessarily insignificant. I can say our experience with working with Congressman Blumenauer on the Personalize Your Care Act, there has been some organizations who have been opposed to implementing these codes, but I think there still remains some kind of political toxicity with advanced care planning. The good thing is that the advanced care plan codes, as they're sort of promulgated throughout the rulemaking process, that's a little bit more insulated and a little more protected from the kind of political will on Capitol Hill. So it's, I think that there's some sensitivity would probably be the best word that I can use to describe the way in which Medicare is going about trying to implement the codes.
So then I'm going to address Cecilia Maschenbacher's question first, and then we'll get to a couple of other questions. So Cecilia asked, with regard to the CPT codes and the wording other healthcare professionals, is there any indication of the type of education or certification would be deemed eligible? And more specifically, will nurse practitioners qualify to utilize these codes? And again, this is really a local or state regulatory issue. So, for example, in California, there's a training that's about to jump off that will allow nurse practitioners and physician's assistants to sign PULSE forms. And part of what the end-of-life care program at Sarah Lawrence College is looking at is this very question, and can we provide the training so that either in physicians' offices or in other settings, folks can be certified to do this, to provide advanced care planning and make it billable for either for the primary care practitioner's office or other settings. So we will be keeping you all informed about that. Beth asked, I have read that Medicare is considering loosening the restriction that a hospice patient must forego all life-saving treatment. Do you have any specifics or viewpoint on these possible changes? So Beth, what you heard is about a 35-state trial of hospice care that will allow folks to continue to get acute treatment, including chemotherapy, as well as palliative care, and then also links to advanced care planning and quality of life conversations. And I can't say which states those are at the moment, but we can send out information about that to everyone as well. So then I think there's a question, is there any organized opposition to this change to include reimbursement?
I don't think I can.
Gosh, yeah.
I would just kind of add a little bit of comment to that. If you look at and if you have read kind of the healthcare press around these proposals, there's been kind of comment and pointing back to that these are the things that were called death panels back in the ACA, but there doesn't seem to be the same kind of movement, if you will, the same sort of fervor against advanced care planning code that we saw 5 years ago. So I'm sure there are organizations who are opposed to the implementation of the code. There tends to be organizations opposed to any particular change that you pick out of a regulatory proposal hat. But the kind of tenor and tone of the conversation is just substantively different this go around.
We have a raised hand, so I'm not quite sure what your phone number is, Helene, but we'll unmute you and get your question here in a sec. If you could text to the chairperson your phone number, we'll unmute you. The next question we have is, let's see, let me get into the questions box here. So so Deborah, can you answer Beth Abbott's next question?
Wait, I'm sorry. The one on specifics that must be included in the discussions?
Yes.
Well, yes. There are no specifics at this point, to the best of my knowledge, because these are discussions that are, at this point, not often engaged in by physicians and families. I just was reading something that Health Affairs posted on their blog about the fact that even among people over 65, fewer than half of people even have advanced directives. So it's a difficult conversation. And as Rebecca pointed out just a moment ago, one of the things that we want to do in the end-of-life care planning program is to create some standards around the sorts of things that need to be asked. And that's going to be, I think, the next frontier for us. At this point, we are going to be thrilled if physicians are able to be reimbursed. Physicians and other qualified medical professionals can be reimbursed for the time they spend having quality conversations. Well, obviously the question is, well, what's a quality conversation? And while it can start with some of the documents that are associated with end-of-life planning, it needs to get to, as you well know, those questions that are innate within a patient, whether that patient is sick now or not. So again, that's the next frontier, and I think there are a number of initiatives going on. I see Kathy Gould says she makes reference to the IHI Conversation Project, which is preparing to educate hospital staff and medical and nursing students. So again, we've got to come up with ways. At least we now know that any doctor who wants to broach the topic, or any family member or patient, the doctor may be reimbursed for that time.
So I see Helene.
The conference has been unmuted.
Helene Schaumbach, you would like
Hi.
to? Yes. Go ahead.
Hi. I'm curious in regards to how the bioethicists are feeling about this. Will this be different for Medicaid patients as opposed to Medicare patients, because end of life is a struggle for both categories?
So this is Rebecca. This doesn't apply to Medicaid. It's just Medicare Plan B.
Okay, thank you.
You're welcome. Michelle Weston, you have a question?
Yes, can you hear me?
Yes, go ahead.
I was curious in regards to the bioethicists, how are they feeling about this and the law, and is this something that they are backing in regards to going from, being able to cross state lines and so forth in regards to law and regulations?
So we're going to remute everyone, and Joshua's going to take that question.
The conference has been muted.
I am not entirely sure that I can answer the question from a sort of bioethics, what the kind of leaders in the field of bioethics are thinking about this. I would suspect that there are kind of folks on multiple ends to this question in the bioethics community. And again, I would sort of go back to say, there doesn't seem to be there seems to be an emerging consensus around healthcare providers and around kind of the healthcare community that we need to have advanced care planning be a kind of a core piece of the care continuum. So I think that's probably the best way I can characterize it, is that there seems to be a place in the healthcare continuum for advanced care planning.
Thank you. Just a couple last questions and then a few more slides. So we have a question referring back to this multi-state trial of a kind of combination of hospice, entitled care, and acute treatment. And the question is from Jennifer Bowman. From what I read of the plan, which is being funded by Medicare, that hospice would not be responsible for all the costs of active treatment. But that's a really good question, and I think this is a really good area of investigation and ongoing conversation for all of us who are interested in innovation around end-of-life care. So we'll be paying attention to that. Mary Ann Snyder asked if there's implications for APRNs to provide advanced care planning and bill for these services. So again, who gets to bill is going to be up to your local and state regulatory bodies. But if you're going to comment, this is one of the areas to comment on. Who should be incentivized to do this? It should be as broadly as possible. It should be medical social workers, counseling social workers. It should be all varieties of nurse practitioners and other primary care practitioners. It should make it possible for people to get trained in order to do this in medical and healthcare settings, not just in the doctor's office. I think Joshua mentioned assisted living and nursing homes and other settings. So please comment and please do the poll that's coming up next. So you can go ahead and vote, and we'll see the responses. Did you find the information in this webinar helpful? This is to help us to know what you learned and want to learn. So these are the results so far. I'm going to move to the next poll because time is quickly trotting along here. We would like to know if you are going to comment at regulations.gov. So a couple of you already have, and the majority of respondents say that you will. That's great. So I want to thank you for your great questions and participation in our learning together about this necessary and very needed rule change. I'll just say a couple things about the Sarah Lawrence College End-of-Life Care Program. So we're new, and we're happy to be a part of this burgeoning area of policy debate, health consumer concern, and medical and healthcare innovation. We provide information, tools, and analysis that informs and furthers the changes in medical practice and culture that a comprehensive approach to end-of-life care requires. Our approach is multidisciplinary, and our offerings are Our offerings are easily accessible online, in person, and in blended learning environments. Our program closely aligns with the Institute of Medicine's Dying in America report and its recommendations. We seek to increase knowledge of and access to advocacy for comprehensive care and utilization of advanced care planning, as well as building and understanding of palliative care as a resource for person-centered care. We have a few upcoming events. November and December, we have webinars that will hopefully help us think about the implementation of this Medicare B Advanced Care Planning Code, both for health professionals and for the general public. And we'll be running our second Narrating the End of Life workshop, which is Narrative Practice, Historical Context, and Critical Skills to Improve End-of-Life Care. It's a one-day session with Sayantani Dasgupta, for those of you who know her. And you will be receiving an email with a link to the archived version of this presentation. Before that email, you'll be receiving Deborah's suggested comments and a link or two to some of the other questions that you all asked. So I just want to do a big thank you to the staff of Graduate and Professional Studies, especially Leslie Hunt, Crystal Green, and Katrina Brown, and special thanks to Joshua Lapps and Deborah Jones. We're grateful for your time and knowledge, and thanks everyone for attending. There's one more poll coming. So, would you like to hear more about our end-of-life care programs? Thank you for that response. For more information, here are some links. They will be in the follow-up email. Again, our thanks, and hope to see you, hear you online and in person soon. If you have any other comments, feel free to leave them here.